Hey guys, are you able to see and hear me? I think you're able to see and hear me. My audio visuals are clear, by the way. If yes, you can just give a thumbs up button so that we can start the session. It's been nice meeting you all after a long time. Are you guys there? Just give me a thumbs up so that we can start the session. If you can see and hear me properly. Yes. Thank you so much, Kirti. So, this is a kind of a 1 hour session I would like to do. Probably not the entire set of revision with regards to INI-CET, but I thought I would do a kind of topics that will be asked in INI-CET, by the way. So I have like around 25 MCQs, and trust me, these are the kind of topics that you're gonna get in an INI-CET exams for sure. So I've been seeing the papers closely for the last 3-4 years, and what I've deduced is the fact that there are some topics and there are some areas that INI-CET never misses out on those, and that's what we're going to discuss today. So let us discuss from MCQ perspective. So here is your first MCQ. You have a 8-year-old man who's being evaluated for sudden paralysis of the right side, and the MRI is shown here. So what do you see in the MRI? So that's what the question is gonna be. So is it acute ischemic stroke, or is it cerebral hemorrhage, or is it going to be epidural hematoma, or is it going to be post-reversible encephalopathy syndrome? So they given two things over here. It's a pretty simple one. So what I want to emphasize is the fact that in INI-CET questions and in INI-CET exam, stroke is such an important topic. You should never miss out on ischemic stroke. Especially the treatment aspect of ischemic stroke is going to be extremely crucial and extremely important. Never miss out on this topic. So that's why I just kept a model question with regards to ischemic stroke. And what you're seeing is a diffusion weighted MRI, and what I'm seeing here is a perfusion weighted MRI. And of course, whenever you see diffusion weighted and a perfusion weighted MRI, of course, the only diagnosis that is possible is going to be a acute ischemic stroke, and this is a no-brainer. So this is a very, very simple question and don't need any explanation at all. And what you're seeing in this particular MRI is the fact that you're seeing a kind of infarct. Okay, so whatever you're seeing in diffusion weighted MRI is a kind of an infarct. Okay, number one. And whatever you see in perfusion weighted MRI are basically ischemic zones. So what I'm seeing here is basically ischemia. So why we do diffusion weighted MRI and perfusion weighted MRI in some patients with ischemic stroke is the fact that we need to know the volume of the infarct. So once we know the volume of the infarct, what we are going to do is we are going to see the areas of ischemia, and we are going to look at whether is there any mismatch between the infarcted areas and the ischemic zones. And in this example, you can see a clear picture where there is a clear-cut mismatch between the size of the infarct and the ischemic territory. So what I'm trying to say is there is a kind of a large area at risk which is ischemic and it is underperfused, but you have a very small area that is dead already. So infarct means it's a dead tissue. So there is a very big mismatch between the dead tissue and the ischemic zones and the ischemic territories. So these patients might be eligible for endovascular treatment. So that is what you need to know. So first of all, let me give you a rapid idea of how we are going to evaluate a patient with ischemic stroke, or how we are going to treat a patient with ischemic stroke, so that you will understand things better. So first, any patient with acute focal neurological deficit in your emergency, you're going to consider it as stroke unless proved otherwise. So the next investigation is gonna be a non-contrast CT. So everyone knows that this is the first investigation. So in case if you're seeing hemorrhage in the non-contrast CT, you're going to follow the hemorrhagic stroke pathway. You're not going to follow the ischemic stroke pathway. In case if you don't see hemorrhage in the NCCT, and if the patient is presenting with acute focal neurological deficit that is consistent with the stroke pattern, then definitely you're going to see whether the patient is a candidate for thrombolysis or not. So if the patient is eligible for thrombolysis, for what you're waiting for, you're definitely going to proceed with thrombolysis in the first place. So if yes, then do thrombolysis. And where you do thrombolysis, most of the times you're going to do thrombolysis in the CT room itself. You don't even wait for anything else. Just lyse the patient in the CT room. And we know there are two agents that are basically approved for thrombolysis in this situation. One is going to be the alteplase, which is also referred to as RTPA, and a newer drug that is approved for this indication is going to be the tenecteplase. FDA has recommended alteplase because tenecteplase data is upcoming and it is not a time-tested drug, but still latest reports say that tenecteplase is also as effective as alteplase. In fact, it may be better than alteplase itself. That's what the latest reports are saying. Nevertheless, so these are two drugs that are approved for thrombolysis in the first place. In case if the patient is not eligible for thrombolysis, which means if they are outside the window period. So you know the window period for thrombolysis, we use something called as last seen well time when it comes to thrombolysis, when the patient's attendant has seen the patient talking and walking well like before. If the patient's last seen well time is gonna be less than 4.5 hours, then you can say that the patient is eligible for thrombolysis. In case if the patient's last seen well time is more than 4.5 hours, they will not be eligible for thrombolysis, by the way. And of course, eligibility doesn't mean only the last seen well time. You have to also look at the contraindications for thrombolysis. If it is there or the patient is outside the window period, then probably you have to do something called a CT angiogram. That's the most important step. So in the CT angiogram, what you're going to see is whether the patient is having a large vessel occlusion or not. So if the patient doesn't have large vessel occlusion in the CT scan, then definitely you're going to stop there. It's a kind of a dead end and you're going to go for standard medical care. Beyond that, there's nothing you can do for these patients. In case if you're going to see a large vessel occlusion, you know what are the large vessels? In the anterior territory, you're going to have the internal carotid artery, you're going to have your middle cerebral artery and anterior cerebral artery, and in the posterior circulation you're going to have the vertebrobasilar system and you have the posterior cerebral artery. So these are going to be the large vessels. If you're going to see some large vessel occlusion in the CT angiogram, then again you have to see the last seen well time, whether it is less than 6 hours or not. In case if the last seen well time is less than 6 hours, then you can perform endovascular therapy. So maybe I can write it over here, so to be even more easier. If your answer is yes, look whether the patient is eligible for endovascular therapy or not. If the patient is eligible for endovascular therapy, straight away proceed to endovascular therapy. There is no need to see anything beyond that point. In case if the patient is presenting beyond 6 hours, okay, if the last seen well time is more than 6 hours, they are outside the window period, still you can consider endovascular therapy, provided if they're having mismatch in the perfusion imaging. So remember, the patient is still in the CT room, patient is still receiving thrombolysis. In the CT angiogram, you have found out large vessel occlusion, and if the patient is not presenting within 6 hours, then you're going to perform something called as CT perfusion imaging. Of course, the alternative for your NCCT, will be your diffusion varied imaging. Okay, because diffusion varied imaging is the best kind of imaging that you can perform in any patient with ischemic stroke, because the earliest changes in ischemic stroke is best visualized in diffusion weighted sequences only. So DWI sequences is an alternative to NCCT in centers where MRI is very readily available, because to do diffusion weighted sequences alone, it's going to take hardly like 5 to 10 minutes and nothing more than that. If you're going to perform the entire sequence, then it's going to be time taking, but we're not going to do that. In a patient with suspected stroke, just perform diffusion weighted sequences. And the alternative to CT perfusion imaging will be MR perfusion imaging. This is the image I've shown in the previous slide itself. You can see I performed diffusion weighted imaging and perfusion weighted imaging. So what you're going to see in these patients is whether the patient is having a mismatch or not. That's the most important thing. So if the patient is having a mismatch, okay, gross mismatch, you can actually perform endovascular treatment up to 24 hours. Okay, up to 24 hours you can perform endovascular treatment. Many modern data are coming in favor of endovascular therapy even up to 48 hours in case of posterior circulation stroke, but I don't want to confuse you regarding that. But just remember, like, you can perform endovascular treatment up to a period of 24 hours, provided if you have demonstrated that mismatch. Okay, so mismatch means we're talking about a picture similar to this. If you are able to demonstrate this mismatch, you can perform endovascular treatment up to a period of approximately 24 hours. And apart from that, you have other eligibility criteria for endovascular treatment, which is again beyond the scope of the current discussion. So I'm not going to discuss in this session probably. So I think this algorithm makes a lot of sense, isn't it? Because you need to know at what time what investigations has to be performed. The first investigation is going to be NCCT, no matter what. Then, irrespective of whether the patient is eligible for thrombolysis or not, you're going to perform a CT angiogram. I forgot to say that even while the thrombolysis is being performed, you're going to definitely perform a CT angiogram. So the moment you start the lytic agent, you need to perform CT angiogram in the first place. So the first investigation will be NCCT. The second investigation, irrespective of whether the patient is having eligibility for thrombolysis or not, you're going to perform CT angiogram. And CT perfusion imaging will be the third imaging modality, which will be recommended in selected group of patients. For example, if the patient is having large vessel occlusion and if the patient is presenting beyond 6 hours, then you might consider CT perfusion imaging. And if the CT perfusion imaging in these patients are going to demonstrate a mismatch in ischemia versus the infarct, then probably you can consider endovascular therapy in this patient. So this is a very simplified, elegant algorithm which will help you understand at what time you're going to perform what sort of investigations. Okay, going to the second question now. So this is a very easy one. Which condition is most consistent with these fundus changes in a woman with headache and blurred vision? Of course, this is a patient who is presenting with papilledema. So whenever you see a patient with papilledema, you're going to think about raised ICP, right? So whenever you're seeing a patient with papilledema, you're going to think about a patient with raised ICP. So of course, CSF leakage is not going to produce papilledema. CSF leakage is actually going to produce intracranial hypotension. So we know that it's going to produce intracranial hypotension. So diabetes mellitus is a condition that of course is not going to produce papilledema as well. Hypertension might have produced papilledema, but diabetes is not a condition that's going to produce papilledema. In diabetes, you're going to see more of your microaneurysms, which is going to manifest as dot blot hemorrhages. You can see cotton wool spots, you can see hard exudates, and you can see neovascularization, and you can see macular edema, but it's not papilledema. That's a common finding, isn't it? So that's not a possibility. In ischemic optic neuropathy, you're going to see a different picture. Okay, you're not going to see papilledema though. So the right answer for this question, of course, is going to be pseudotumor cerebri, otherwise referred to as something called as idiopathic intracranial hypertension, previously also referred to as something called as benign intracranial hypertension. So what is the clinching point here? So most of the patients are going to present with a chronic headache, and they will be having some risk factors like endocrine problems. It could be hypothyroidism, or patients can have acromegaly, or they might be using recombinant growth hormone, or most of the females are going to be obese and they might be using oral contraceptive pills nevertheless. So definitely there will be some background risk factors, or they may not have risk factors, but the main presentation is going to be chronic headache. And in these patients, if you look at the fundus, you're going to see papilledema for sure. So which means there is a clear-cut evidence that the patient is having raised intracranial pressure. And apart from that, you're gonna look at some focal neurological deficits. It may be present sometimes. And the most common focal neurological deficit that you're gonna expect in patients with idiopathic intracranial hypertension is going to be bilateral cranial nerve 6 palsy. So this is one of the most common. So we know that CN6 palsy is a kind of a false localizing sign. So many times if you see a cranial nerve 6 palsy, that is abducens palsy, that is lateral rectus palsy, you might think that the problem is with the 6th nerve. Actually, it may not be. It may be due to raised intracranial pressure that may result in the development of bilateral 6th cranial nerve palsy. So that's a kind of a false localizing. That's very commonly seen in conditions with raised ICP, including patients with idiopathic intracranial hypertension. So what are you going to do here? So you're going to do an imaging, preferably an MRI. So what are you going to see? Relatively normal. So in the sense like you don't see anything much with regards to MRI, or sometimes the radiologist might say that the patient is having empty sella syndrome. Please understand that empty sella is a radiological diagnosis. It is not a clinical diagnosis. I'll repeat, empty sella is a radiological diagnosis and it's not a clinical diagnosis. Empty sella can be associated with pituitary insufficiency, or empty sella may be associated with idiopathic intracranial hypertension, or empty sella may be a completely normal finding in the sense like Patient may not have any manifestations of empty cella at all. So that's a radiological finding. You need to always know it with a pinch of salt. And now you don't have any clue. So the MRI is, obviously normal, and you're going to opt for something called as CSF manometry. So CSF manometry, this is going to be the clincher. In CSF manometry, you're going to see very high opening pressures. You know, the normal opening pressures in CSF manometry is going to be 5 to 20 centimeters of water, or we can say 50 to 200 millimeters of water. But it's always better to know in terms of centimeters of water. The normal range is 5 to 20 centimeters of water. And obviously in these patients, it's going to be elevated. It's going to be high. And that's going to clinch the diagnosis. That makes the diagnosis of idiopathic intracranial hypertension, and treatment is going to be with astazolamide. And we have two other options, surgical options also. In case astazolamide doesn't work out, maybe you can go for surgical options like lumboperitoneal shunt, or probably you can opt for optic nerve fenestration, depending on what is the primary problem of the patient. The primary problem of the patient is headache, then lumboperitoneal shunt will be optimal. The primary problem of the patient is visual field defects because of papilledema, then optic nerve fenestration may be a ideal option. So this is a pretty easy question. The right answer for that question is option D. And coming to this one, you have a young female with complaints of bone pain and abdominal cramps. His family gives history of abnormal behavior. The consultant doctor, based on clinical feature, made a diagnosis already. Which of the following will be the best investigation to arrive at a diagnosis? Of course, this patient is presenting with the classic manifestation of primary hyperparathyroidism, of course. So PHPT, you know how the PHPT is going to present with. Primary hyperparathyroidism is going to present with stones, groans and moans. So this patient is having bone pain, that is because of high PTH, and the patient is presenting with abdominal groans, that is probably because of peptic ulcer disease, and probably because of constipation to some extent as well, because of hypercalcemia causing histamine release that produces peptic ulcer disease. And hypercalcemia also slows down your gut, and that can also be the reason for development of constipation. So abdominal groans are basically due to either peptic ulcer disease caused by hypercalcemia or constipation caused by hypercalcemia, or combination of both together. His family also gives a history of abnormal behavior. So probably this is the psychic modes that we are talking about, and this is usually because of microcalcifications in the brain, and of course sometimes your basal ganglia may be calcified as a part of metastatic calcification in hypercalcemia and hyperparathyroidism, or something like that is happening. So you have the classic history that is suggestive of a primary hyperparathyroidism. So arrive at a definitive diagnosis, you need to localize where is the problem. Actually, if you look at the stepwise approach, so this patients should be undergoing serum calcium testing first. So of course, if the serum calcium is increased, then the next step will be to look at the PTH. PTH will be the next step. So here you need to see whether PTH is elevated or PTH is suppressed. If the PTH is elevated, you're going to think about PTH dependent hypercalcemia. PTH dependent hypercalcemia. If the PTH is suppressed, you're going to think about PTH independent forms of hypercalcemia. Remember, in the entire world, more than 80% of the cases of hypercalcemia will be due to either hyperparathyroidism, that is, we're talking about a primary hyperparathyroidism, or it's going to be because of malignancy. These two causes alone contribute to almost 80% of the cases of hypercalcemia. In that, if you look at malignancy, if they ask you what is the reason for malignancy causing hypercalcemia, it is basically due to PTH related peptide followed by lytic metastasis. So the most common mechanism of malignancy causing hypercalcemia will be due to PTH related peptide production. And primary hyperparathyroidism is also one of the important causes. So these two causes alone, let me repeat, is going to result in almost 80% plus cases of hypercalcemia. So primary hyperparathyroidism is going to be a PTH dependent cause, and malignancy is going to be a PTH independent cause, where the PTH levels will be suppressed. So if it's PTH dependent, then the next step will be to look at the urinary calcium. That's a very, very important point. So if the urinary calcium is increased, that clinches the diagnosis of primary hyperparathyroidism, that is PHPT. And if the urinary calcium is suppressed, then you probably think about a benign condition called as FHH, that is familial hypocalciuric hypercalcemia. So once you know that the patient is having primary hyperparathyroidism, you need to find out what are the glands that are abnormal. So I'll repeat, what are the glands that are abnormal. So most often than not, you're going to talk about sporadic cases. Sporadic forms of primary hyperparathyroidism are the most common forms. Rarely you can have familial and genetic variants. Rarely you can have familial and genetic variants, in the sense you're talking about some conditions like men syndromes. Like men 1 and men 2A syndromes are known to produce familial forms of primary hyperparathyroidism. So what is the main difference between sporadic forms and familial forms? Sporadic forms commonly tend to affect a single gland. Sporadic forms usually tend to affect only one particular gland. And the most common parathyroid gland that is affected in a patient with sporadic primary hyperparathyroidism is going to be the right inferior gland. I'll repeat, it's going to be the right inferior gland that's going to be more commonly affected in cases of sporadic primary hyperparathyroidism. But in case of familial primary hyperparathyroidism, you're going to have involvement of all the glands, or I can use the term multiglandular. It's not going to be single gland, it's going to be multiglandular most often than not. So we have to know what glands are involved. So that is the reason why we are going to perform some localizing studies like Sestam-AB scan. So Sestam-AB scan alone will not be helpful, to be honest. So you're going to perform Sestam-AB scan, and this has to be coupled with some sort of imaging modality, like for example an ultrasound or the CT scan of the neck. Any one has to be done along with Sestam-AB. So there are a lot of reasons for that. I cannot discuss that right now, but I can say that Sestam-AB scan alone is not enough, but in exams it's a very, very important question. That is important to localize where the abnormality is, in which gland the abnormality is. So based on that only we can proceed towards surgery in case if we want. So in PTH independent causes, you have plenty of conditions that can produce PTH independent hypercalcemia, but as far as I know, the malignancy part is going to be the most important. And this is a very, very important cause, malignant hypercalcemia. And apart from that, we have conditions like vitamin D toxicity, we have conditions like sarcoidosis, we have conditions like Milk-Alkali syndrome, and we do have conditions like lymphoma. We have plenty of conditions that can produce hypercalcemia, but I would say that malignancy is going to be the most important here. So all you need to know is PTH dependent, PTH independent. PTH high, think about primary hyperparathyroidism in most cases, and PTH, if it's suppressed, you think about malignancy in most cases. Even though MRI and CT scan are done probably along with the Sestam-AB scan, but it's not going to replace your Sestam-AB scan. So that's going to be the answer for this question. Even ultrasound can be done along with Sestam-AB scan, but I'm not going to replace those investigations for the sake of replacing with Sestam-AB scan. I'm going to perform along with Sestam-AB scan. So that's the take home point. So the right answer for this question is going to be option A. It's an easy one. So coming to fourth MCQ, you have a 56-year-old patient with a history of systemic lupus erythematosus and is admitted to the hospital for lethargy, hematuria and acute kidney injury. Imaging demonstrates normal sized kidneys with parenchymal disease. The patient's urinalysis shows red blood cell counts with proteinuria of 3.5 milligrams per deciliter. I think 3.5 grams per deciliter, but nevertheless, biopsy return showing diffuse lupus nephritis. That's a class 4 lupus nephritis. And what is the next step in the management? So this patient is having a class 4 lupus nephritis, which means this is the most common class of lupus nephritis. I think most of us would have studied what are the different classes of lupus nephritis, because in AIIMS exam, most of the times examiners tend to test on lupus nephritis and something about SLE. If you look at the past 3 years papers, you're almost always getting one question on SLE. So that's why I thought like I will include a topic on lupus nephritis. So we know that when it comes to lupus nephritis, you have 6 classes. You have class 1 lupus nephritis, you have class 2 lupus nephritis, you have class 3 lupus nephritis, you have class 4 lupus nephritis, and you have class 5 lupus nephritis, and you have class 6 lupus nephritis. So how class 1, we know it's also called as focal mesangial, or some textbooks use the minimal mesangial, even though the modern name is minimal mesangial. Class 2 is going to be diffuse mesangial. Okay, class 3 is going to be focal proliferative. I think you all know what is the definition of focal and diffuse. Focal means less than 50% of glomerulus. Diffuse means more than 50% of the glomerulus. So class 4 means it's going to be diffuse proliferative type, and class 5 is going to be the membranous variety, and class 6 is going to be advanced sclerosing variety, where more than 90% of the glomerulus will be sclerosed. So how the presentations are going to be? So class 1 and class 2 is going to present in an asymptomatic fashion, and generally we don't treat class 1 and class 2, so we just observe them. In case of some proteinuria, we can maybe using AC inhibitors or ARBs, but apart from that we don't treat the class 1 and class 2 lupus nephritis in general. And class 3, class 4 and class 5 patients will be symptomatic and they need treatment. You have to treat with some sort of immunosuppression, that is mandatory for class 3, class 4 and class 5, because there is a very high risk of progression towards end stage renal disease. And class 6, if you really ask, class 6 I'm gonna not treat with immunosuppression, so I don't need immunosuppression as far as class 6 is concerned. I don't need immunosuppression as far as class 6 is concerned, because these patients are going to present as ESRD or ESKD, which means already the kidneys are done and dusted. So these patients are presenting with end-stage renal disease and manifestations of ESRD like uremia and uremic manifestations. Why the hell I need immunosuppression for these people? So I'm not going to go for any sort of immunosuppression. So for class 2, class 3 and class 4, class 3, class 4 and class 5, definitely I'm going to require immunosuppression. What sort of immunosuppression is the question? In that we need to know how class 3 and class 4 are going to present. Class 3 and class 4 are going to present with nephritic syndrome. Okay, they're going to present with nephritic syndrome. Nephritic syndrome in a sense, they're going to present with glomerular nephritis. When you talk about glomerular nephritis, most of the times you're going to talk about high serum creatinine, and they're going to present with RBC casts in the urine, and of course they'll be having some sort of proteinuria, and they might be having hypertension. That's how they're going to present. So this is the nephritic presentation. But your class 5 patients are going to have a nephrotic presentation. So you know what do you mean by nephrotic presentation? These patients are going to actually present with proteinuria. So that's the idea. So how you're going to treat class 3 and class 4 lupus nephritis? Class 3 and class 4 lupus nephritis typically will be treated with high level immunosuppression. We're going to use high dose corticosteroids, like I can use a IV methylprednisolone, or probably I might be using a high dose oral prednisolone also. But generally it's a common practice to prefer a high dose IV methylprednisolone, like 1 gram pulse dose IV methylprednisolone. Along with it I'm going to use cyclophosphamide, okay, or some other alternative agents also can be preferred. Like for example, I can even prefer a mycophenolate mofetil for this case, and most consultants nowadays actually are preferring mycophenolate mofetil ahead of cyclophosphamide, because cyclophosphamide is a very, very toxic drug. It's an alkylating agent. And this is the induction regime, and there is something called maintenance regime. For maintenance I'm going to use corticosteroids plus MMF or azathioprine, but in general MMF will be preferred because it can be used for induction and can be used for maintenance as well. And what about your class 5? Class 5 lupus nephritis. For class 5 lupus nephritis, you can use corticosteroid plus MMF induction therapy, and of course maintenance will be with, of course you're going to maintain with either mycophenolate mofetil or azathioprine, but mycophenolate mofetil is going to be a better option in this case. So remember, even though during the maintenance period we are going to continue corticosteroids for a short period of time, quickly within a short period of time it's important that you have to stop corticosteroids and you have to continue with one of these drugs, either with mycophenolate mofetil or azathioprine. But most of the studies say that mycophenolate mofetil is a better agent for maintenance compared to that of azathioprine. So here the patient is actually having a class 4 lupus nephritis, which means they are going to, this patient is typically having a nephritic presentation. So definitely I'm going to use a corticosteroid plus a cyclophosphamide for induction. But you have to understand that alternative to the cyclophosphamide will be a mycophenolate mofetil. So MMF also can be used as a alternative to cyclophosphamide. Azathioprine is a typical maintenance regime, so I'm not going to use for induction. Intravenous methylprednisolone alone will not be definitely enough, and rituximab can be tried in refractory lupus nephritis. In first attack of lupus nephritis, usually we don't try rituximab, whereas in refractory lupus nephritis, definitely rituximab is an option. You can try it. It's an approved drug for refractory lupus nephritis, but not for this patient who's having an initial attack of diffuse proliferative lupus nephritis. So Many students know that in lupus nephritis, very commonly you can see something called as wire loop lesions, which is a light microscopic finding. That is because of thick capillaries, and that is because of deposition of immune complexes around these capillaries. And you can see something called as a full house pattern as well. So what do you mean by full house pattern? All the stains will be positive: IgG, IgM, kappa, lambda, then fibrinogen, then you have C3, C1q. So almost all the stains will be positive. So that's what we call it as a full house pattern. So this is also quite common in patients with lupus nephritis. And the most common form of lupus nephritis, of course, class 4 lupus nephritis. That's another point that you need to know. So this slide will tell you what is the overall treatment that you're gonna do in case of lupus nephritis. So again, here is your vaginous granulomatosis is also almost the same treatment. There is not much any difference. Prithvi has asked about vaginous. But when you have a RPG-like picture, when you have a crescentic glomerulonephritis, or you're going to have a rapidly progressing glomerulonephritis-like picture, then probably you can add plasma exchange also, because plasma exchange is indicated in patients with rapidly progressing glomerulonephritis. So same regime, I'm going to use, so for example, if they ask you what is the treatment of RPGN, so because somebody has asked about that, so RPGN, how you're going to treat, so I'll write here. So RPGN will be treated with IV methylprednisolone, plus you can use either cyclophosphamide or rituximab, any one can be used. Along with it, I'm going to use a plasma exchange also. This is the usual treatment for RPGN, especially if it is due to vaginous granulomatosis or some sort of vasculitis, because PEX is an approved therapy for patients with rapidly progressing glomerulonephritis. So coming to question number 5. So this is another important area, because infective endocarditis is something that's very commonly asked in your exams. Hi Metazilo. So he's from Neuros. Happy to hear. And you have a 59-year-old woman who's been diagnosed with enterococcal endocarditis. Okay, she has no known drug allergies. What will be the standard therapy for this patient? So remember, when you talk about enterococcus, we are talking about two species, Enterococcus faecium and Enterococcus faecalis. Luckily, infective endocarditis most of the times will be due to an organism called as Enterococcus faecalis rather than Enterococcus faecium, because Enterococcus faecium is known to be highly drug resistant. So most of the times when they straight away they bluntly ask about Enterococcus, the treatment of choice will be ampicillin plus gentamicin. Generally, in infective endocarditis patients, we use gentamicin for the purpose of synergy. So the right answer for this question is going to be a straightforward option C. There's no doubt about that, because penicillin G alone will not be enough. And vancomycin can be tried as an alternative. So in case if the patient is allergic, to penicillin, then probably vancomycin could be an option. If the patient is allergic to penicillin, then vancomycin could be an option. But if the patient is not allergic, that's why they have clearly mentioned that the patient has no known drug allergies. So in that situation, a beta-lactam or a penicillin like ampicillin alone might be more than enough. In case Prithvi is asking about daptomycin, linezolid, can we try or not? You can try, provided if the culture reports come as vancomycin resistant enterococcus. In case if the patient is having a vancomycin resistant enterococcus, then you can probably try linezolid or daptomycin. In fact, daptomycin is an excellent drug. Okay, it's an excellent drug for the sake of your infective endocarditis, because it's very good drug for septicemia caused by resistant gram-positive organisms. So if they have mentioned specifically a vancomycin resistant enterococcus, then these are going to be very good options. If they have not mentioned about vancomycin resistant enterococcus, then this is going to be the standard treatment. Look at the last 2 to 3 years papers. There has been plenty of questions on infective endocarditis in different forms. That's why I thought I will make a question on infective endocarditis, and the right answer for this question is going to be option C. It's simple and straightforward. Coming to 6th MCQ, again it's a question on hypertensive emergency, and again if you look at the last 3-4 years papers, there have been very huge pile of questions with regards to your hypertensive emergencies. You have a 50-year-old woman presenting to the emergency department with pulsating headache and dizziness. She has been non-compliant with her blood pressure medications over the past month. She's taking lisinopril, metoprolol. Her BP is 245 upon 120 millimeters of mercury, and her heart rate is 88 beats per minute. She also has splinter hemorrhages and cotton wool spots on ophthalmic examination. What is the best option among the choices listed? So it's very clear that she may be probably suffering from Yeah, she may be suffering from malignant hypertension with papilledema, and the best course of action here is going to be labetalol. Remember, labetalol is the first line IV antihypertensive drug in most hypertensive emergencies. In most hypertensive emergencies, you're going to use labetalol. Ischemic stroke, labetalol. Then probably hemorrhagic stroke. Again, I'm going to use labetalol as the first choice drug. Acute kidney injury, even though some textbooks give phenol-dopam and so many other drugs, but still in India you don't have all those drugs. You're going to use labetalol only, even in patients with acute kidney injury and some sort of hypertensive emergency. Think about even other hypertensive emergencies, like for example, pregnancy-related hypertensive emergencies like eclampsia, preeclampsia. You're going to use labetalol. And most of the hypertensive emergencies are going to be managed with labetalol. Even aortic dissection with hypertension, how you're going to manage? You're going to manage with IV beta blockers. Even though textbooks mention esmolol as a first choice drug in aortic dissection, honestly speaking, you don't have esmolol in practice. Where is esmolol in India? Where is phenol-dopam in India? So you don't have these drugs in India. So we have only labetalol right now. So anyways, that's why examiners are going to be so fond of this drug, because in India you don't have much options. So Prithvi is asking about nicardipine. I don't think nicardipine is available anywhere in India. Are you able to see and hear me now? Okay. I think there was a small trouble. I think the network has gone, and we have got it back. Yes, not a problem. So let me repeat. I think there was some network lag. So where it was stuck, can you let me know, so that we can start from that area? Nicardipine. Okay, fine. I think this is where it got stuck. So I'll rub all of this, because you'll not be understanding anything then. So I was telling that nicardipine and clevidipine are drugs that are not available in India right now. So we are going to use anyway labetalol for most hypertensive emergencies. So anyway, I'll come back to the choices in a while, but where you're going to use nitroglycerin. Nitroglycerin can be preferred in patients with acute coronary syndrome, or probably you can prefer in patients with acute heart failure. So these are the two areas where you're going to prefer nitroglycerin, because in these two situations, nitroglycerin is going to reduce the preload, so that it's going to be beneficial in that situation. Otherwise, even in acute coronary syndrome, we don't only use nitroglycerin, we can use labetalol, because beta blockers are very, very beneficial in patients with acute coronary syndrome. But remember, if the patient is having acute heart failure, I cannot use labetalol as the first choice, because beta blockers are contraindicated in patients with acute heart failure, especially in patients with decompensated acute heart failure. So phentolamine may be a choice. It's an alpha blocker. Maybe if the patient is suffering from pheochromocytoma, then phentolamine may be a choice. Clonidine is not usually used in most hypertensive emergencies. Probably the only reason I'm going to use clonidine in practice is going to be the place where patient has withdrawn clonidine, and on top of that, patient is presenting with rebound hypertension. If this is the case, the patient has withdrawn from clonidine, plus if the patient is having rebound hypertension, then maybe I can use clonidine again, because the problem here is clonidine withdrawal. So apart from this indication, there is no much reason for using clonidine in the first place. So what are going to be the choices of antihypertensive drugs? Whenever you talk about a stroke, whether it's an ischemic stroke or whether it's a hemorrhagic stroke, so ischemic or a hemorrhagic stroke, you're going to use labetalol as the first choice. In case if they ask you the alternatives to labetalol, then maybe nicardipine or clevidipine may be an alternative. They are excellent choices, but unfortunately, as I told you, nicardipine and clevidipine are not available in India so far. And if they mention something called aortic dissection, then again labetalol is going to be the choice. But if there is esmolol in the option, then probably you can opt for esmolol, but I don't think esmolol is available in India. IV esmolol is not there. So that's why even in aortic dissection, I'm going to use labetalol as the first choice. And in case if they ask about something called as coronary artery disease, then probably I'm going to use nitroglycerin plus or minus. Along with that, I can use a combination with labetalol unless until the patient is having acute heart failure. But if they ask about specifically acute heart failure, then nitroglycerin will be the preferred choice. If they ask about pheochromocytoma and pheocrisis causing hypertensive emergency, then probably you can use something called as phenoxybenzamine. So if phenoxybenzamine is not there in the option, then probably phentolamine could be an option. You're going to use any non-specific beta blocker. I mean non-specific alpha blocker or non-selective alpha blocker. That's it. So for all pregnancy-related complications, pregnancy-related hypertensive emergencies, once again IV labetalol will be the drug of choice. So these are the different drug choices that you can try in different hypertensive emergencies. So wherever you're going to use labetalol, alternative for labetalol will be your nicardipine and clevidipine. That's it. Espanol can precipitate bronchial asthma. Yes, of course. Espanol, even though it's a pure beta select, I mean you're talking about a beta 1 selective beta blocker, but still at high doses the selectivity will be lost. So if the patient is having severe reactive airways disease like severe bronchial asthma or severe COPD, still I would say don't give beta blockers, especially if the patient has recent exacerbation that has especially caused a hospital admission. I don't think I can use beta blockers in such a patient. So you are thinking selectivity means you are thinking that drugs will act only on one particular receptor. No, it's not like that. At high doses, the selectivity may be lost. That's why I'm not going to take a chance if the patient is having a recent exacerbation, especially if the recent exacerbation has resulted in hospitalization. I'm not going to use beta blockers because it's contraindicated. Okay, all right. Now coming to 7th MCQ, you have a 22-year-old soldier who's brought by his fellow squad mates after a 10-mile ruck march in which the patient collapsed at mile 9. The squad mates are concerned because the patient has been talking nonsensically and will not answer to their questions properly. Rectal temperature shows 104.4 degree Fahrenheit. You immediately begin implementing cooling measures and place the patient under water immersion. At what temperature you should remove the patient from water immersion? So which means this patient is actually suffering from a sort of heat stroke. This patient is suffering from heat stroke technically. So there is another entity called heat exhaustion. So how will you differentiate between heat stroke and heat exhaustion? Because environmental emergencies is another area that very commonly examiners are going to target. Especially the heat and cold related illness is something that is very important for your exams, especially INI-CET as well as your NEET exam. So in simple ways, if you want to differentiate between heat stroke and heat exhaustion, just look at certain things. First, look at the temperature. If the core body temperature is less than 40, more than 40.5 degrees Celsius, always think about the possibility of heat stroke. If the patient is having a temperature of less than 40.5 degrees Celsius, you think about minor illness like heat exhaustion. And in heat stroke, most of the patients will be having altered mental status. And in heat exhaustion, most of the patients will have a clear sensorium. So here very clearly the patient is having a temperature of more than 40.5 degrees Celsius, which means definitely the patient's temperature is more than 40.5. So it is very likely to be a heat stroke and not a heat exhaustion. And this patient is talking nonsensically, which means this patient is having altered mental status. Even that is suggestive of a heat stroke rather than heat exhaustion. And some textbooks say that classical heat stroke is going to have no sweating, which means the patient will be dry, whereas sweating will be intact in patients with heat exhaustion. So this is going to apply only for the classical heat stroke, even though exertional heat stroke sometimes can be associated with sweating. But nevertheless, in exams, most of the times whenever they talk about heat stroke, just think about a classic heat stroke unless proved otherwise. If they are specifically given that a person who's an athlete who's training heavily, and during training if they suffer heat stroke, that will be an exertional heat stroke. That's different. Unless and until they have mentioned a very young patient who's an athlete during training, if they develop heat stroke, only in that situation diagnose an exertional heat stroke. Otherwise, in all practical situations, if there is a mention about heat stroke, it's always a classical heat stroke only. So the immediate treatment for any heat stroke is going to be cooling. So the rapid cooling is going to be the most important treatment for any forms of heat stroke. So classically, you're going to use ice water immersion. You can use like water at normal body temperature also, but that's not going to be that effective. So going to use ice water immersion. That's going to be the most effective measure. Or even you can infuse cold saline also. Even that will be effective. But ideally, we're going to use ice water immersion. So at what temperature we're going to stop cooling? Actually, it is 101.5 to 102 degree Fahrenheit. This is the exact Harrison statement. This is given in Harrison. honestly. So at exactly at 101.5 to 102 degree Fahrenheit, you're going to stop the cooling, which means active cooling will be stopped. After that, you remove all the cooling measures and remove the patient from cooling and allow them to cool down automatically. Once the temperature goes to that 101.5 to 102 degree Fahrenheit, then the cooling will become an automatic process. So if they ask you what are the indications for stopping cooling, okay, stopping the active cooling. Number one, once the patient starts shivering, okay, you have to stop the active cooling, because once the shivering occurs means you can think about that the hypothalamus is responding well now, so you can stop the cooling. And second, if the temperature reaches 101.5 to 102 degree Fahrenheit, okay. So what is the rate of cooling? Generally, rate of cooling, even this can be asked in exams, rate of cooling will be approximately 0.37 degree Fahrenheit per minute. So this is the usual rate of cooling that you are expected to achieve, that is around 0.37 degree Fahrenheit per minute. So right answer for that question is option D. So you have a 23-year-old female presenting with abdominal pain and vomiting approximately 5 hours after ingestion of Tylenol, that is nothing but acetaminophen, or otherwise we're going to call it as paracetamol, okay, in an apparent suicidal attempt. Lab work returns with acetaminophen level of approximately 184 micrograms per liter. So definitely anything more than 40, we're going to take it as very significant, but nevertheless it's elevated. That's what you need to know. So when considering N-acetylcysteine in this patient, which statement is true? So look at statement number 1. So N-acetylcysteine prevents renal toxicity by detoxifying NAPK and decreasing NAPK production. Okay, they're asking which statement is true, isn't it? So N-acetylcysteine does not prevent renal toxicity, even though it detoxifies NAPK by probably replenishing the glutathione stores, and it does prevent the liver injury. It has nothing to do with renal toxicity. That's a very, very important point. So option A is wrong. So N-acetylcysteine has nothing to do with renal injury, because paracetamol poisoning also tend to produce acute kidney injury, and that cannot be prevented by giving N-acetylcysteine. Only the liver toxicity can be prevented by giving N-acetylcysteine. And honestly speaking, N-acetylcysteine doesn't decrease the NAPK production. It only actually reduces the toxic effects of NAPK. It increases the metabolism of NAPK towards non-toxic compounds by replenishing glutathione. So anyway, this is a wrong statement. This is not a correct statement. And option B, nearly 30% of patients treated with N-acetylcysteine will develop anaphylactic reactions. This is a wrong statement as well. Only like hardly 5% patients may develop anaphylactic reactions, but definitely not more than that. And option D, PONAC, that is oral N-acetylcysteine, is superior to IV N-acetylcysteine in patients presenting within 8 to 24 hours. It's wrong. So in patients presenting within 8 hours, then oral N-acetylcysteine is almost equally efficacious as that of IV N-acetylcysteine. But if the patient is presenting beyond 8 hours, then IV N-acetylcysteine is considered to be superior, because if they are presenting very late, like more than 8 hours, then the chance of ongoing liver injury will be very, very high. That's why IV N-acetylcysteine is preferred in patients beyond 8 hours. But if the patient is presenting within 8 hours, both oral as well as IV N-acetylcysteine is going to be equally efficacious. So the right answer for this question is option C, N-acetylcysteine. Whether it crosses the placenta or not, yes, of course it crosses the placenta, and it is absolutely safe in pregnancy. In fact, this property of N-acetylcysteine to cross the placenta is beneficial, because paracetamol also can produce fetal hepatic necrosis. I'll repeat, paracetamol in excess, if the mother is taking too much of paracetamol, that can cause fetal hepatic necrosis, and fetal hepatic necrosis can be prevented by N-acetylcysteine. And that's why this movement of N-acetylcysteine across placenta is actually beneficial for the fetus. It's safe, plus it's beneficial for the fetus also. So right answer for this question is going to be option C. Coming to the 9th MCQ, you have a 24-year-old male who is brought in the emergency medical services after a cycling accident. EMS states that they found a pelvic instability wrapped in and wrapped his pelvis in a bed sheet. His pressures en route were around 90/70 with a heart rate of 112 beats per minute, and EMS has started a 1 liter normal saline. On examination, you find a positive fast exam and initiate a massive transfusion protocol. Which of the following is not likely an adverse effect of massive transfusion of blood products? So, you know, metabolic alkalosis is a effect of massive transfusion because of citrate toxicity. Everyone knows that. citrate toxicity, and if the liver is functioning normally, then it's going to result in metabolic alkalosis only. Hypokalemia can also occur in patients with massive toxicity, even though hyperkalemia can also occur in massive transfusion. And hypothermia is also a problem of massive transfusion that can trigger a massive transfusion. I mean, that can be a problem in massive transfusion because of cold blood products. But what you don't really get is hypercalcemia. Hypercalcemia is something that you don't really expect in patients with massive transfusion. So why? Because of citrate toxicity and metabolic alkalosis, all you're gonna expect is actually a hypocalcemia and not really a hypercalcemia. So what are the problems of massive transfusion? So whenever you're going to talk about massive transfusion, what are the problems that you're going to face? Number one, citrate toxicity. This is the most important. Citrate toxicity is going to result in metabolic alkalosis, and along with that you're going to result in reduced ionic calcium. Remember, the total calcium may still be normal, so you should not confuse with that. The total calcium may still be normal, and what you're going to see is actually low levels of ionic calcium. So the free calcium is the one that's metabolically active, and that is the one that's going to be reduced in patients with citrate toxicity. The total calcium though may be normal, and this metabolic alkalosis can trigger hypokalemia also, because we know whenever the patient is having significant alkalosis has a hypokalemic effect, and this can result in development of even hypokalemia, because alkalosis can push the extracellular potassium into the ICF. So movement of potassium will occur from ECF to ICF. So that's the reason you can result in hypokalemia also. Even option C is a correct statement. And second, hyperkalemia is also a possibility, especially if you're using old RBCs. If you're not using fresh PRBCs, then hyperkalemia is also a complication because of the lysed RBCs that have released potassium already in the blood packet. And number three, patients can result in hypothermia because in massive transfusion, you don't have time to warm the blood products. So you might be infusing like very fast. So that's the reason why you might end up with hypothermia. And of course, patients can result in coagulopathy. So most of the times this coagulopathy is going to be dilutional coagulopathy. And this really occurs if you don't use adequate amount of your plasma products like FFP and platelets. So what are the features of coagulopathy? You are going to have elevated PT, APTT and INR. That is because of dilution of the clotting factors, and patients can have dilutional thrombocytopenia as well. And this can be avoided by following the massive transfusion protocol, where you're going to use PRBCs, FFPs and platelets in a ratio of ideally 1:1:1. That can probably prevent the development of this dilutional coagulopathy due to massive transfusions. The right answer for this question though is going to be option A. It's pretty simple and straightforward. So hypercalcemia is not a feature. So here you have the 10th MCQ. A 63-year-old previously healthy woman with no significant medical history develops an abnormal EKG following a repair of closed femur fracture sustained in a high-speed motor vehicle crash. The procedure was notable for a mild tachycardia and hypotension, but otherwise uncomplicated. ECG shows 1 to 2 mm ST segment elevations in leads V2 to V4 and deep T-wave inversions in V5, V6 and AVL. Serum troponin is 0.8 and the patient undergoes an emergency coronary angiography which reveals no evidence of acute coronary occlusion. Which of the following additional findings is likely to be present? Okay, so this patient is someone who's undergoing a kind of a trauma. So this patient has had a femur fracture because of high-speed motor vehicle crash, and after that the patient is having a kind of abnormal EKG, which means the patient has developed ST elevations and the coronaries were actually clean. Okay, so patient is not having any evidence of acute coronary occlusion. So here the patient is having some sort of like exertion or a mental exertion. On top of that, yes, patient has had a STEMI-like picture and the troponin is also elevated. It's 0.8. Remember, anything more than 0.1 is definitely elevated. So I've not given the normal values, but though anything more than 0.1 is definitely elevated. So this patient is having a STEMI-like picture, but you don't have any evidence of acute coronary occlusion. So ideally the right answer for this is epikinetic LV, apex and probably mid-ventricular segments, because you are talking about something called as stress-induced cardiomyopathy. among the stress-induced cardiomyopathy, if the patient is having the apical dilatation, it will be called as Takotsubo. But remember, patient can have dilatation of the mid-ventricular segments also. If that is the case, it will not be called as Takotsubo. The patient is having apical dilatation or apical ballooning, that specific type of stress cardiomyopathy will be called as Takotsubo cardiomyopathy. And some of the key features of Takotsubo cardiomyopathy, most of them will be postmenopausal females. 99% cases will be postmenopausal females, and there will be history of some emotional disturbance. Remember, it may be because of some loss of loved one, or it may be because of some physical trauma to them also. Some sort of like mental emotion will be going on in that patient, and they will present with chest pain. Chest pain is the most common presenting symptom, and they can have a characteristic STEMI like picture. They can have ST elevation, and they can even have a troponin elevation. Okay, and in echocardiogram, you're going to see LV dilatation. Okay, and this LV dilatation will be in the non-coronary distribution. This is a very, very important point. LV dilatation will be in the non-coronary distribution. If it's in the coronary distribution, you can think about coronary artery disease, but it will be typical in the non-coronary distribution. So in exam, like if the examiner is very liberal, he might use the term apical ballooning. Okay, they might use the term apical ballooning. So if the examiner is so liberal, and of course this doesn't confirm whether the patient is having Takotsubo or stress cardiomyopathy or not. You need to follow up with a coronary angiogram. In case if you do a coronary angiogram, there you might notice that the patient is having a clean coronaries. Clean coronaries means you don't have a significant coronary artery disease. So that will probably retrogradely confirm that the patient is having a stress cardiomyopathy or a Takotsubo cardiomyopathy. So I would say like stress cardiomyopathy is a kind of a diagnosis of exclusion. So the right answer for this question is option D. Definitely it's not severe MR. Severe MR would have had other findings like your pansystolic murmur and so on. So it's definitely not severe MR. Coronaries are clean. So option A is a kind of a dummy choice. You're not going to expect any multivessel high-grade stenosis. Some people are asking what is ramus intermedius. Ramus intermedius is like a trifurcation of your left coronary artery. Normally, what should happen? Your left coronary artery should bifurcate. It's not trifurcate. It bifurcates into left anterior descending artery and left circumflex. But in patients with ramus intermedius, the left coronary artery, so this is the left main coronary artery, and that's going to trifurcate. Trifurcate in the sense you're going to have a left circumflex, you're going to have a LAD, so this will be the left main coronary artery, this will be the LAD, and this will be the circumflex, and there will be another intermediate branch. This is what we refer to as ramus intermedius. So this is just a normal anatomical variant and nothing more than that. This is nothing but what? This is a normal anatomical variant. This is what we called as ramus intermedius. So this is seen in approximately, I think, around 20% of the cases. This anatomical variant is seen in approximately 20% cases. So that again is just to confuse you, nothing more than that. So it's not a right answer. So ramus intermedius is a normal anatomical variant. It's nothing but a trifurcation of the left main coronary artery rather than normal bifurcations. The right answer for this question though is going to be option D. So coming to MCQ number 11. So what is the impression based on the ECG given below? I know that ECG is a definite question in your INI-CET exams for sure. So what the ECG is showing basically. So if you look at the ECG very carefully, what you're seeing are kind of delta waves. That's what you're seeing here. So in almost most of the leads, what you're seeing here are going to be the delta waves. In most leads, what you're noticing are the short PR intervals, and of course you're seeing delta waves that you are seeing here. So very short PR in most of the leads, especially in the limb leads, and in most of the limb leads also you're seeing the slight slurring of the initial part of the QRS complex. So again, this is straightforward one. So the right answer for this is Wolff-Parkinson-White syndrome. It's not actually right ventricular hypertrophy, because if it's gonna be a right ventricular hypertrophy, you're going to have very tall R waves in V1. You're not going to have this much big S waves in V1 at all. You're going to have very tall R waves in V1 without big S waves. So that's not the case here. So if it's a dextrocardia, you're going to see reverse progression in V1 to V6, and that is not happening here. So this is unlikely to be a dextrocardia as well. And this patient, if it's going to be a left ventricular hypertrophy, you're going to see big S wave in V1 with big R wave in V5, V6. That is not the case here. So this is very likely to be a Wolff-Parkinson-White syndrome. Okay. So then what about this one? 12th MCQ. So you have a 42-year-old woman with end-stage renal disease due to IgA nephropathy, received deceased donor kidney transplant 2 weeks ago. Her HLA match was 6 out of 6. She had a low-level HLA type 1 donor-specific antibodies, but cross-match was negative. She received basiliximab for induction. She underwent allograft kidney biopsy due to high creatinine. Biopsy showed glomerulitis and peritubular capillaritis and positive C4D staining. What should be the best management for this patient? So again, INI-CET is very notorious for asking these sort of questions, in the sense they tend to ask like the renal transplant questions more often than not. If you look at the last 2-3 years papers, most of the questions are clustered around the renal transplant, so in the nephrology section. So that is the reason I have specifically given this question. And notoriously, renal transplant based questions in INI-CET are very, very tough. They're not easy questions at all. And what is the right answer for this? Here you are basically suggesting a acute rejection. Okay, the findings are very much suggestive of acute rejection. Acute rejection, there are two types of rejection. One is acute cellular rejection, and second is going to be acute antibody mediated rejection. So in cellular rejection, you're going to see only peritubular capillaritis plus or minus glomerulitis. But the moment if you see C4D staining, it is almost always equivalent to antibody mediated rejection. Okay, antibody mediated rejection. So whenever you think in terms of rejection, you're going to immediately start with treatment. So if it's an acute cellular rejection, then the treatment will be high dose corticosteroids. Like immediately we start with IV methylprednisolone, plus you can use anti-thymocyte globulin. So that's going to be the most important treatment for acute cellular rejection. Yes, C4D positivity gives away the answer. Yes, correct. So if it's an antibody mediated staining, I'm going to use corticosteroids, plus I can use plasma exchange, plus I can use IVIG, plus or minus I can use rituximab. So when it is antibody mediated rejection, then all of this treatment can be tried. So right answer for this question is going to be option C, IVIG plus steroid plus plasma pheresis plus rituximab. And if it's acute cellular rejection, then probably option D would have been the right answer, but actually it is antibody mediated rejection. BK virus PCR, I'm not suspecting a BK virus nephropathy here, so definitely that's not going to be the choice. In exam, if you see the term decoy cells, then probably you can think about BK virus nephropathy, but that's not the case here. Donor specific antibodies, yes, that's done in most cases, but that's the second best answer I would say for this question. But it will be done only after initiating the treatment, so you're not going to do that at the expense of treatment. So you can do that later on, but what comes first in this kind of emergency is actually the treatment. So start treatment first. The right answer for this question is going to be option C. Look at this question. You have a 40-year-old gentleman who came with complaints of vomiting since 3 days. Her blood gas analysis shows the following findings. You have a pH of 7.22, you have a bicarbonate of 9, PaCO2 of 21, and what's going to be your inference? So technically I'm going to write out, it's a very easy question honestly. So bicarbonate is 9 and PaCO2 is 21. So first look at where the patient is having acidosis or alkalosis. This patient is actually having acidosis. And look at the bicarbonate, it's low. Look at the carbon dioxide, is low. When the arrows are moving in the same direction, you need to work out the problem further. So you need to find out the primary disorder. You know that here the bicarbonate is the one that is responsible for the acidosis. So the primary problem here is going to be metabolic acidosis and nothing more than that. And this low bicarbonate is going to be a compensation. This low bicarbonate is basically a compensation. I mean low PaCO2 is basically a compensation here. You need to find out the expected PaCO2. Okay, expected PaCO2 and whether the compensation is correct or not. So what is the expected PaCO2 here? You by Winter's formula, expected PaCO2 will be equivalent to serum bicarbonate into 1.5 plus 8. Okay, so Winter's formula. So what is the serum bicarbonate here? The serum bicarbonate is 9 multiplied by 1.5 plus 8. So 9 times 1.5 you're going to get 13.5 plus 8 is going to be 21.5. So 21.5 plus or minus 2. So the range is going to be, because plus or minus 2 always we give as a correction factor. So it's going to be somewhere around 19.5 to 23.5. That's the range. And of course the patient's PaCO2 is within the expected range. So it's within. So within the expected range of PaCO2, so the right answer is metabolic acidosis only. The patient is not having any additional disorder because the PaCO2 is within the expected range. So it's a simple, straightforward metabolic acidosis, and the right answer for this question is going to be option B. So look at this question. A 47-year-old woman with SLE presents for routine follow-up. Current medications include HCQ and ibuprofen, that is an NSAID. Physical examination is normal. Urinalysis shows a pH of 6.5 and a calcium phosphate crystal. A basic metabolic panel shows the following: ABG 7.33, PaCO2 is 33, and PO2 is 96. Calculates 138 sodium, potassium 3, chlorine 110, and bicarbonate 16. The best explanation for this patient's metabolic disorder is what? Is it type 1, type 2, type 3, or type 4 RTA? Most of the times type 3 RTA is just a dummy choice. We don't have anything called type 3 RTA in the current practice. All we have is either a type 1, type 2, or a type 4 RTA. So it is not a type 4 RTA because type 4 RTA patients will be having hyperkalemia. So this patient is having hypokalemia. So that cannot be a type 4 RTA. So it must be either a type 1 or a type 2 RTA. There are a lot of giveaways in this question. So first of all, if you look at connective tissue disorders, when you talk about a connective tissue disorder like SLE causing RTA, it's almost always a type 1 RTA. Okay, it's going to be a distal RTA. So if they give Sjogren syndrome, think about distal RTA. SLE, think about distal RTA. Sarcoidosis, think about distal RTA. So whenever you talk about a connective tissue disorder, always think about a distal RTA. It's going to be a type 1 RTA. And that's simple and straightforward. And most of the times, patients with renal tubular acidosis is going to have a patients with renal tubular acidosis is going to have a normal and a metabolic acidosis. That are common things. So in exam, how will you differentiate between a type 1 renal tubular acidosis and a type 2 renal tubular acidosis? Type 1 is proximal, type 2 is distal, isn't it? So the common thing between type 1 and type 2 RTA will be your normal and metabolic acidosis, and both of these patients are going to have hypokalemia. So this is a normal thing. But what will be the differentiating point? So in type 1 RTA, that is distal, DRTA, that is distal RTA, acidosis will be very severe. Generally the bicarbonate levels will be less than 18. In type 2 RTA, generally the bicarbonate levels will be more than 18. There will be only a milder degree of acidosis. And type 2 RTA patients will be having bicarbonaturia. So I can write something called as bicarbonate urea. Bicarbonaturia. And these patients are also going to have Fanconi syndrome, which is nothing but a triad of glycosuria, phosphaturia, and aminasuria. And because of the Fanconi syndrome, many patients can have bone loss. And because of that, they can end up with fractures. And type 1 RTA, on the other hand, will have one peculiar picture called as nephrolithiasis. Renal stones. Nephrolithiasis is very, very characteristic. Or they can have nephrocalcinosis. They may not give just nephrolithiasis. They can use the term nephrocalcinosis. That's a very characteristic feature of a type 1 distal RTA. And number 3, the urinary pH. Urinary pH will always be more than 5.5 when it comes to type 1 distal RTA, but it can be less than 5.5 in patients with type 2 RTA. Even though urinary pH can be variable in patients with type 2 proximal RTA, but in distal RTA, it can never become acidic. Urinary pH will always almost be alkaline because the distal nephron is the one that acidifies the urine. It's impossible to have an acidic urine in patients with type 1 RTA. So these are the constellation of findings. I can clearly see that the patient is having more severe hypokalemia and a more severe metabolic acidosis, and together with the background of systemic lupus erythematosus, it's a straightforward answer. I'm going to make a diagnosis of type 1 distal RTA only. So if it's going to be like type 2 RTA, they would have given other clues like bicarbonate would have been 18 or 19, and patient would have had bicarbonaturia, patient would have had Fanconi picture, patient would have had osteomalacia, and probably patient would have had fracture history, and they would have given the urinary pH. So there could be some other clues, but here it's straightforward type 1 distal RTA. So going to question number 15, you have a 27-year-old female who develops eye pain and reduced visual acuity following the initiation of treatment for a recently diagnosed Graves' disease. Which one of the following treatments is likely to have been started? So AIMS, again, INI-CET people love the thyroid ophthalmopathy. That is nothing but the Graves' ophthalmopathy. So we all know that whenever you start with radioactive iodine ablation, many patients, whenever you start with radioactive iodine ablation, many patients tend to have flare-up of their underlying ophthalmopathy. That is why if you look at the contraindications to radioactive iodine ablation, so they would have given number 1 is actually suspected thyroid cancer. So that's the most sensible and the number one contraindication. In anyone with suspected thyroid cancer, you're not going to give radioactive iodine ablation, you're going to only go for surgery. Second is moderate to severe ophthalmopathy. Moderate to severe Graves' ophthalmopathy. So there are other contraindications that is very easy to understand. For example, patients who are pregnant or patients who are lactating, and you're not going to use radioactive iodine ablation in those people. But I would say the most sensible contraindication for radioactive iodine ablation would be suspected cancer and moderate to severe Graves' ophthalmopathy. That is because the radioactive iodine ablation treatment can worsen ophthalmopathy. So that's what exactly the question is mentioning. So what has actually worsened the ophthalmopathy here is actually the radioactive iodine ablation. As simple as that. So that's the right answer for this question. So coming to MCQ number 16, which medical comorbidity is the strongest contraindication to starting SGLT2 inhibitors? Okay, we are talking about the gliflozins, dapagliflozin, empagliflozin, canagliflozin, and so on. So of course, it's a very, very simple question. So it's recurrent UTI, urinary tract infection. I'm not going to use this drug because gliflozins tend to increase the risk of urinary tract infection, and especially genitourinary candidiasis. Candidiasis risk is very high with all these SGLT2 inhibitors because of high concentration of glucose in the urine. And in ischemic heart disease, it's actually a very, very important drug because there are only two class of drugs that reduce the cardiovascular mortality. One is SGLT2 inhibitors and second is going to be the GLP-1 analogs. So these are very, very important class of drugs I'm going to use in ischemic heart failure, ischemic heart disease and heart failure patients for sure. COPD, I don't think you have anything to do with COPD and gliflozins, and I don't think you have anything to do with rheumatoid arthritis and gliflozins. So the right answer for this question is going to be option C, that is recurrent urinary tract infection. Coming to 17th MCQ, you have a 43-year-old gentleman present with 5 weeks of progressive dyspnea and intermittent fever, not responsive to 5 days of azithromycin followed by 2 weeks of levofloxacin. There was a significant deterioration in his clinical course. Her laboratory findings are normal except for a slightly elevated ESR and a white blood cell count. A chest X-ray is taken which is considered bilateral areas of consolidation. What is the most likely diagnosis that is confirmed over here? 1 second, I think I have to just... Okay, so what is the most likely diagnosis that you're dealing with here? So here you can't make a diagnosis of ABPA because when you talk about allergic bronchopulmonary aspergillosis, you need to have history of bronchial asthma. There will be worsening bronchial asthma, or at least there will be history of cystic fibrosis. And apart from that, you have to have fleeting infiltrates. Patient will be having fleeting infiltrates in imaging, and you will be able to see evidence of mucus plugs in imaging as well. You will be able to see evidence of mucus plugs in imaging that can produce some signs like finger in glove sign, even that can be produced. Okay, so fleeting infiltrates. And apart from that, most of the patients will be having eosinophilia, elevated eosinophils, and they're going to have very high level of IG. Okay, so it's not actually allergic bronchopulmonary aspergillosis. It's unlikely. And is it idiopathic pulmonary fibrosis or not? No, definitely not. IPF doesn't present this way. Most of the patients will be elderly, more than 50 years of age, and they're not going to present with like intermittent fevers and progressive dyspnea. Rather, they're going to present with fibrosis and fibrotic features, and this is not how your IPF is going to present. And it's not Goodpasture syndrome, because Goodpasture syndrome is going to present in a very different way. They're going to present with pulmonary renal syndrome, isn't it? So you're going to have history of AKI, and the patient will be having hemoptysis and history that is suggestive of involvement of the lungs also, because here the problem is anti-glomerular base membrane antibody. Without kidney injury, how can you make a diagnosis of Goodpasture syndrome? That's also the wrong answer. So the right answer for this question is BOOP, that is bronchiolitis obliterans organizing pneumonia. And the other name, so there is an other name for BOOP that is called as COP. COP means cryptogenic organizing pneumonia. I'll repeat, COP means cryptogenic organizing pneumonia. That's the correct name, current name for bronchiolitis obliterans organizing pneumonia. So how COP is going to present? Typically, COP is going to present in a subacute fashion. It will not have a chronic presentation. Many ILDs will have a chronic presentation, but COP is something that's going to have a kind of a subacute presentation. In the sense, they're going to have a pneumonia-like picture. They're going to have a pneumonia-like picture. So pneumonia-like picture means they will have fever and progressive dyspnea and progressing cough that is not responding to antibiotics. Pneumonia-like picture that is not responding to antibiotics. Even if you take imaging, a CT scan or probably an X-ray, still you're going to see pneumonia-like presentation. Like for example, you can see consolidation areas. So because the patient is having pneumonia-like picture, many times many local practitioners and even in tertiary care centers, they would have given multiple rounds of antibiotics. And giving multiple rounds of antibiotics is also one important clue for diagnosis of COP in exams. So how will you make a diagnosis of COP? By the way, of course, the gold standard investigation is going to be biopsy. So in biopsy, what you're going to see, I think in the pathology they would have taught you, you will see something called as plugs of granulation tissue in the bronchioles. I'll repeat, plugs of granulation tissue in the bronchioles. That is what you're going to see in the biopsy. And once you have ruled out secondary causes that cause granulation tissue and organizing pneumonia, you can make a diagnosis of cryptogenic organizing pneumonia, that is COP. But remember, you have a lot of secondary conditions that can cause organizing pneumonia, especially infections, and that has to be ruled out. Then only you can make a diagnosis of cryptogenic organizing pneumonia. So the biopsy is the gold standard investigation, and that's going to clinch the diagnosis. And treatment of COP is going to be with immunosuppression. In the sense, you're going to start with probably steroids and nothing more than that. And maybe sometimes in patients who don't respond to steroids or don't have, those who are having some problems with steroids, you can give additional therapy with other forms of immunosuppression. Otherwise, the treatment of choice here is going to be immunosuppressive therapy, especially with corticosteroids. If you know that much, it's going to be more than enough. Let us move to the next question. Which of the following are features of bronchial asthma is most likely to indicate a life-threatening attack? So what are the features of bronchial asthma? That's going to tell you that the patient is having a life-threatening attack is the question. So is it failure to improve after salbutamol nebulization, or if the saturation is 93%, or if the respiratory rate of 42 per minute, or if the PFR is 30% of predicted? So what do you think is going to indicate a life-threatening attack? So first of all, there are many guidelines that tells you whether the patient is having a mild attack or moderate attack or severe attack or life-threatening attack. So what I'm telling is from the BTS guidelines, that is British Thoracic Society guidelines, which is commonly used by the GINA guidelines also. So as per the definition, if you want to call it as a moderate exacerbation of bronchial asthma, then the PFR will be in the range of 50 to 75% of predicted, and the patient will have a normal speech. Patient should not have any problems in speech, and the respiratory rate should be less than 25 beats per minute, and the heart rate should be less than 110 beats per minute. If you want to call it as a severe attack of bronchial asthma, then the PFR will be in the range of 33 to 50%, and the patient will not be able to speak normally, which means if they use the term, the patient can't complete sentences in one breath. So if they can't complete sentences in one breath, that's a very important point that tells you that the patient is having severe attack of bronchial asthma, or if the respiratory rate is more than 25 breaths per minute, or if the heart rate is more than 110. All these are going to indicate that the patient is having severe bronchial asthma. Or some textbooks may use the term pulsus paradoxus. So if they use the term pulsus paradoxus, or if they use the term silent chest, all this indicates a severe attack of bronchial asthma. But I would say there is another entity called as like life-threatening bronchial asthma, life-threatening attack, or patients are having impending respiratory failure. So whenever the PFR is less than 33%, it's a sign of impending respiratory failure. If the patient is having a silent chest, it's a sign of impending respiratory failure. If the patient is having bradycardia, hypotension, again this is a sign of impending respiratory failure. The patient is having bradycardia or hypotension, definitely it's a sign of impending respiratory failure. Or if the patient is having cyanosis, it's also a sign of an impending respiratory failure. Or alternatively, if the patient is in altered mental status, confusion, coma because of severe hypoxemia to the brain, even that is a sign of an impending respiratory failure. Or if they give increased PaCO2, if the carbon dioxide levels increase, actually in acute exacerbation of bronchial asthma, your carbon dioxide levels will be low, it should be less, because it's a type 1 respiratory failure. But if the carbon dioxide levels are increased, okay, so then definitely that's a kind of a life-threatening attack, indicates an impending respiratory failure. And probably I would say another one called as abdominal paradox. Normally during inspiration, your abdomen tends to like probably like distend out, isn't it? It's going to come out, pop out because of the movement of the diaphragm down. And during expiration, abdomen has to move back in. This is a normal respiratory pattern. But if there is a reverse, so during inspiration, if the abdomen moves in, and during expiration, if the abdomen moves out, that indicates a very severe obstruction. So that is also a sign of a impending respiratory failure. So whenever you have a life-threatening attack, intubate the patient. That's the most important point. So obviously you would have guessed by now. So failure to improve after salpingo nebulization is not at all a feature. Saturation, and again saturation of less than 92% is a sign of severe attack, but here they have given saturation of 93%, which is not a sign of a severe attack, and respirator of 42 is not a sign of severe attack, but definitely PFR of 30% is going to be a sign of severe attack. Okay, so right answer for this question is going to be option C. And going to the next question, you have a 31-year-old smoker who's seen in the emergency room with a 3-day history of worsening left-sided pleuritic chest pain associated with worsening shortness of breath, and the patient has no past medical history. His observations are BP of 78 upon 46 millimeters of mercury, saturations are 81% on 8 liters of oxygen via face mask, and heart rate is 147 and temperature is 37.3 degree, which means it's normal temperature. He appears clammy, pale and unwell. On examination, lung auscultation is normal. ECG shows a sinus tachycardia with right heart strain, and he has not responded to adequate fluid resuscitation after applying high flow oxygen. What is the next best course of action? So what I'm basically suspecting here, this patient is having a pleuritic chest pain, this patient is having unexplained shortness of breath, this patient is having sudden onset hypotension, this patient is having a right heart strain with sinus tachycardia in the ECG. So all these are classical and key features of pulmonary embolism. Okay, so all these are classic and key features of pulmonary embolism. So in case if you're suspecting pulmonary embolism, we know that the treatment of choice is going to be anticoagulation. Yes, anticoagulation, heparin is going to be the treatment of choice. There is absolutely no doubt about that. But here the patient is hypotensive. So if that is the case, so of course anticoagulation is the treatment of choice. I'm not denying that. But here the patient is hypotensive. The patient is in shock. So if the systolic blood pressure is less than 90 millimeters of mercury in a patient with suspected pulmonary embolism, you have to perform urgent IV thrombolysis. So even though the treatment of choice is going to be anticoagulation in patients with pulmonary embolism, so if the patient is hypotensive, the BP is less than, systolic BP is less than 90 millimeters of mercury, you're going to perform only urgent IV thrombolysis. Remember, urgent transesophageal echocardiogram can be done if you are suspecting aortic dissection. So maybe if the patient with aortic dissection is in shock, maybe you can perform a transesophageal echo urgently, so that's fine. Rapid initiation of LMWH, yes, is also a treatment. It's very, very important in pulmonary embolism, but I would say that can be done if the patient is not having hypotension. Okay, if the patient is not having hypotension, then that could be the best course of action. But here the patient is hypotensive, in shock. So IV thrombolysis will be the first choice. Urgent CT pulmonary angiogram, I don't think this is needed right now. And you cannot shift the patient to a CTPA. How can you do a CTPA in this patient who is hypotensive and who's in shock? So I don't think that's the logical step here. So the right answer for this question is urgent IV thrombolysis, and one agent that is approved for thrombolysis in patients with pulmonary embolism is alteplase, that is RTP, and the dose is 100 milligram IV over a period of 2 hours. That is the dose of alteplase. So the right answer is option A, IV thrombolysis. Coming to question number 20. So 36-year-old woman is referred for evaluation because of a 5-year history of Raynaud phenomenon and thickening of skin over fingers. She has calcification of fingers and also reports mild dyspnea while climbing stairs. Routine laboratory tests are within normal limits. An echocardiogram showed a RV diastolic dysfunction with tricuspid regurgitation. The DLCO is 44% of normal with normal lung volumes. What is the likely pulmonary diagnosis in that patient? First of all, her history itself is very, very clear. So there is Raynaud's phenomenon and thickening of the skin over her fingers only. So she is also having calcinosis cutis, and that itself suggests that the patient is having a CREST syndrome. Even if you don't know anything with regards to pulmonary function test, the moment you see CREST syndrome, you're going to make a diagnosis of pulmonary hypertension. So pulmonary hypertension is so common in patients with CREST syndrome, and in fact this is the most common cause of death in patients with CREST syndrome as well. So how pulmonary hypertension is going to present, you're going to have an isolated decline in DLCO. That's how pulmonary hypertension is going to present with. That's the reason why the patient's DLCO is around like 44%. And in pulmonary hypertension, you'll have a normal FEV1, you're going to have a normal FVC, and you're going to have a normal FE1 by FEC ratio, and you're going to have every parameter to be normal. Only there will be an isolated drop in DLCO. And COPD, I don't think it's going to be the answer, because how can you have a normal lung volume if it's a COPD? In COPD patients, the FE1 will be low, the FE1 by FEC ratio will be low, and definitely TLC will be high because it's an obstructive lung disease. In interstitial lung disease, your lung volumes cannot be normal, it must be altered. You're going to have a low FE1, you're going to have a normal FE1 by FEC ratio, and your total lung capacity will be low. So you cannot have normal lung volumes. ILD is not the answer. Probably if they have given a diffuse form of scleroderma, then I would have thought about ILD, but still I need to correlate with other findings properly. Probably if it have thought about a diffuse variety of scleroderma, then ILD maybe probably would have answered. But here Crest syndrome is a limited scleroderma. It's a limited scleroderma. If your skin thickening is limited distal to your knees and elbows, then it's actually limited scleroderma only. And in that situation, pulmonary hypertension is the most common. In diffuse scleroderma, ILD is the most common. Restrictive lung disease secondary to pleural disease usually tends to occur in conditions like asbestosis. Asbestosis is the one that's going to produce RLD secondary to pleural disease. But if it's a restrictive lung disease secondary to pleural disease, your DLC would have been normal. DLC will be normal. DLCO cannot drop in patients with extra parenchymal disease or extrinsic RLD. So ideally that rules out option D also. The right answer for this question is option A. So here is your 21st question. Which of the following should you consider while evaluating a patient with suspected primary forms of hemochromatosis? Remember, not talking about secondary, primary hemochromatosis. So high serum ferritin in a patient with liver disease is diagnostic. No, it's wrong. It's not diagnostic, because high serum ferritin can be seen in any iron overload condition. In any iron overload, you can see high serum ferritin. In any iron overload, you can see high serum ferritin. In the sense, in primary as well as secondary hemochromatosis, you're going to see high serum ferritin. So that's not diagnostic. So testing for HFE genotype is necessary to confirm the diagnosis. That's a correct statement. In fact, the gold standard for diagnosis of hereditary hemochromatosis, that is primary hemochromatosis, is going to be your testing of HFE genotype. And antimitochondrial antibodies are present in most individuals is a wrong statement, because AMA positivity is a feature of PBC, that is primary biliary cholangitis. It's not a feature of hemochromatosis. And evidence of hemolytic anemia and neuropsychiatric symptoms likely is also wrong statement, because this is a feature of Wilson disease. Okay, this is a feature of Wilson disease, and this is not a feature of hereditary hemochromatosis. When you talk about hereditary hemochromatosis, the most common mutation that you're going to encounter in patients with hereditary hemochromatosis is going to be HFE gene mutation. And in the HFE gene, you have two types. One is going to be the C282Y mutation, and second one is going to be the H63D mutation. These are two mutations you're going to encounter in patients with hereditary hemochromatosis. And in that, if they ask you the most common, is actually the C282Y gene mutation. And we have non-HFE gene mutations also. These are rare. These are not common. The best example for non-HFE gene mutation causing hereditary hemochromatosis is going to be, example will be hemojuvenilin mutations, or it could be ferroportin mutations. So hemojuvenilin and ferroportin mutations can result in development of hereditary hemochromatosis as well, but these are exceedingly rare. And hemojuvenilin mutations tend to produce juvenile hemochromatosis or juvenile forms of hemochromatosis. And in case if it's going to be HFE gene mutation, okay, so who's going to develop the disease early? Generally, males are the ones who are going to develop disease early. Females are the ones who are going to develop disease late. If they ask you the most common clinical feature of hereditary hemochromatosis, it's actually fatigue and arthralgia. Fatigue and arthralgia, these are going to be the, okay, fatigue and arthralgia, these are going to be the most common forms of hereditary most common clinical manifestations of hereditary hemochromatosis, fatigue and arthralgia. But you can get other problems also. So what are the other problems that you can encounter? You can develop arthritis, that is hemochromatic arthritis as such, and you can develop cardiomyopathy. Patients can develop hypogonadism, And this is an interesting form because hypogonadism can occur because of two reasons. One, iron deposition in the pituitary can cause hypogonadotropic hypogonadism, and iron deposition in the testicles can cause hypergonadotropic hypogonadism. So it can be due to either pituitary failure or it can be due to either testicular failure also. And patients can develop diabetes mellitus, and patients can develop skin pigmentation also. Patients can develop diabetes mellitus and patients can develop skin pigmentation. That's the reason why it is also referred to as something called as bronze diabetes. The reason for diabetes is basically your pancreatic damage, beta cell damage by iron deposition. So these are going to be the clinical features as such when it comes to your hereditary hemochromatosis. Testing wise, if they ask you the screening test, the first line screening test, or we can say the screening test of choice, is going to be transferrin saturation. Okay, TSAT. I'll repeat, transferrin saturation. You all know how to find out transferrin saturation. It's iron divided by TABC. Iron divided by TABC is the one that's going to tell you the TSAT. Plus or minus, if you want, you can add ferritin, but ferritin is not specific, but TSAT is the first screening test. That's what you need to know. But the confirmatory test will be genetic testing. So you have to do the genotype. So what is the genotype that is associated? So that's what we call it as confirmatory test. And treatment of choice, so I'll write here, treatment of choice for hereditary hemochromatosis will be phlebotomy. In case phlebotomy is contraindicated because of anemia, then you can use iron chelators like deferoxamine or deferoxirox, but the treatment of choice is actually phlebotomy and nothing more than that. So who's going to develop disease early? It's actually the males who are going to develop disease early compared to the females. Why? Because females lose menstrual blood every month. So because they lose menstrual blood every month, it's like kind of a natural phlebotomy for them. That's why they don't really develop disease unless and until they reach the postmenopausal period. That's the time they develop disease if it's a female. Males, they don't lose blood at all, isn't it? So that's the reason why they develop symptoms faster compared to that of female. So even that question could be asked in exams. So that completes our discussion on hereditary hemochromatosis. Now coming to MCQ number 22. You have a 30-year-old female with chronic hepatitis B and HbAg negative status and has no evidence of significant histological disease. Evaluated for treatment, and ALT is 50, HBV DNA is 1800, and no family history of HCC, no history of previous treatment, no evidence of extrahepatic manifestation. What will be the following recommendations for therapy? So this is typical question based on Harrison, nothing more than that. But there are many different form of guidelines. First of all, what are the indications for therapy? Indications for therapy. Okay, in patients with chronic HPV. We're talking about chronic HPV. What are the indications for therapy? First of all, we have the Asian guidelines. That's called APASL guidelines. This is called as Asia Pacific Association Study of Liver Disease. And we have IASL guidelines, which says only one thing that you have to see is HBV DNA. That's all, nothing more than that. If the DNA is more than 2000 international units per ml, you have to start therapy. If it's less than 2000, you need not start therapy. So this is the APASL guidelines. But actually, as practitioners, we follow the APASL and IASL guidelines only. We don't follow the Western guidelines because developing nations are the ones who have a lot of burden with regards to hepatitis B virus. The developing nations don't have that much burden with regards to hepatitis B virus. That's why we don't look at the guidelines from the developed countries. But unfortunately, because your questions may come from Harrison, we need to know the Western guidelines also. So what are the Western guidelines? I'll write separately. So this is what is given in Harrison. So indication number 1, if the patient is having a DNA level of more than 20,000, plus if the ALT is elevated more than 2 times the upper limit of normal, okay, so then definitely it's a straightforward indication for therapy, and if the patient is E antigen positive. Okay, so this is an indication for therapy. Second indication is DNA more than 2000, plus if the ALT is just elevated, if the patient is E antigen negative. So the patient is E antigen negative, DNA level should be more than 2000 and the ALT should be elevated. That is the indication for treatment. Third, patient should have cirrhosis. If the patient has cirrhosis, none of these things matter. Straight away we are going to start the treatment. Or if the patient is having extrahepatic manifestations. Extrahepatic manifestations. Like for example, polyarteritis nodosa, glomerulonephritis, and so on. You know, the most common extrahepatic manifestations with hepatitis B virus is going to be glomerulonephritis. And the most common form of glomerulonephritis is basically your, membranous nephropathy. That's the most common type of glomerulonephritis that you see in patients with hepatitis B virus. Okay. And polydates notice PAN is also very, very important, extrahepatic manifestation. Number 5, if the patient is having high risk of complications like hepatocellular cancer. So what are the example of high risk of complications? If the patient's age is more than 40, or if the patient is having family history of hepatocellular cancer, family history of HCC, then in this situation also you will be able to start therapy. So these are the usual 5 indications for starting therapy. And our patient did not have cirrhosis, did not have extrahepatic manifestations, um, is not more than 40 years, or is still less than 40 years, and the patient's E antigen status is negative. In E antigen negative status, the ALT should be elevated, the ALT is reasonably okay, and the HBV DNA should be more than 2000. Here the HBV DNA is less than 2000. So definitely there is no indication for treatment at this point of time. So remember, in your INI-CET exams, definitely there will be a question on viral hepatitis. These are all very stereotypical questions. That's why I have included this question in this session. And coming to question number 23, which of the following is associated with acidic fluid protein of less than 1 and a serum acidic albumin gradient of more than 1.1? So again, this is a very, very common question in the last 2 years paper. If you take like this, a very common question asked in almost all of the INI-CET exams in the last 3 sessions, if you take specifically. So whenever you see a patient with ascites, look at the SAG ratio. So if the SAG ratio is more than 1.1 or the SAG ratio is less than 1.1, the SAG ratio is more than 1.1, it is equal to portal hypertension unless proved otherwise. It's equal to portal hypertension, that's it. So the next step is going to look at the protein. So see the protein. So the protein levels are less than 2.5 or the protein levels are more than 2.5. The protein levels are less than 2.5, you're talking about sinusoidal causes. We're talking about sinusoidal portal hypertension. So if the protein levels are more than 2.5, we are talking about pre-sinusoidal and post-sinusoidal causes. Pre-sinusoidal and post-sinusoidal causes. So when you talk about sinusoidal causes, we are talking about cirrhosis. Cirrhosis is the most important sinusoidal cause. Our textbooks use a term called as late Budd-Chiari syndrome, because late Budd-Chiari syndrome patients are also going to manifest like cirrhosis only. Of course, the right answer for this question is cirrhosis, because the acidic fluid protein is less than 2.5 and the SAG ratio is more than 1.1. That's it. That itself tells that the patient is actually having alcoholic cirrhosis over here. And apart from that, what are the examples of pre-sinusoidal causes? The best examples will be extrahepatic portal vein obstruction, and there is a condition called NCPF, that is non-cirrhotic portal fibrosis, and even you can think about other conditions like cystosomiasis. Okay, so what are the examples of post-sinusoidal causes? When we talk about post-sinusoidal causes, you're going to talk about right heart failure, you're going to talk about constrictive pericarditis, or probably you're going to talk about a patient with early Budd-Chiari syndrome. Late Budd-Chiari will present like cirrhosis only, but here early Budd-Chiari is the key. So early Budd-Chiari syndrome. So these are the post-sinusoidal causes. And there is another cause called as sinusoidal obstruction syndrome, otherwise called as SOS. Usually occurs after your bone marrow transplant. So even that's an important cause. And if the SAG ratio is less than 1.1, so in case if the SAG ratio is less than 1.1, it is not portal hypertension. It is definitely not portal hypertension. You have to be very, very clear about that. So if it's not portal hypertension, what is it due to? It will be typical exudative causes. Like for example, you can think about peritoneal malignancy. Often it's referred to as peritoneal carcinomatosis. You can think about that cause, or probably you can think about other causes like tuberculosis or pancreatic ascites. Okay, pancreatic ascites, and we have plenty of other types, or Kyles ascites. So we have plenty of other causes, but these things are going to be the most important. So peritoneal malignancy would have had a SAG ratio of less than 1.1, SAG value of less than 1.1, not more than 1.1. Constrictive pericarditis will have a SAG of more than 1.1, but I don't think your protein value will be less than 1. So in constrictive pericarditis, the protein value should have been more than 2.5. And again, veno-occlusive disease being a post-sinusoidal cause, that is veno-occlusive disease is nothing but SOS, that is sinusoidal obstruction syndrome. So in veno-occlusive disease, you should have had a acidic fluid protein of more than 2.5, not less than 1. So definitely even this is not an answer. The right answer for this question is of course alcoholic cirrhosis. And another reason for development of a patient with ascites and a SAG of less than 1.1 is nephrotic syndrome. Even that can be asked in exam. Even nephrotic syndrome tends to have a SAG value of less than 1.1 only, not more than 1.1. Okay, so anyway, we have discussed this question in detail. Let us move on to the next question. You have 24th question. 34-year-old IV drug user admitted with purpuric rash affecting her legs. Blood test revealed the following: HB of 11.4, platelet of 4.89, WBC of 12,300, HCV PCR is positive, which means patient is having a positive HCV RNA. HbSAg is negative and rheumatoid factor is positive. C3, C4 is reduced. What is the most likely diagnosis? It's a straightforward. The moment you see hepatitis C virus, the right answer will be cryo. So obviously, like in the world, the most common cause of cryoglobulinemia is actually hepatitis C virus. If they ask you the most common extrahepatic manifestation of hepatitis C virus, it's cryoglobulinemia. The most common cause of cryoglobulinemia is also going to be hepatitis C virus only, and there is absolutely no doubt about that. So PAN is not the case because PAN is usually associated with hepatitis B surface antigen, and it's not going to be associated with hepatitis C virus. Okay, so and you don't have any big like manifestation of PAN over here. So if it's a PAN, they would have definitely given like imaging picture. So microaneurysms would have been there. If it's a PAN, definitely they would have given microaneurysms, renal and mesenteric microaneurysm. That's not the case. Or they could have given testicular involvement. Testicular involvement is so characteristic of PAN. So none of this is there. So just I'm ruling out PAN as not a possibility. So Henoch joint purpura is a disease of children. So patient's age would have been less than 20, and they have manifested with plenty of other manifestations. And C3, C4 would not have been reduced in Henoch joint purpura. It should have been normal in patients with Henoch joint purpura. And why the hell rheumatoid factor should be positive in patients with Henoch joint purpura? And that's not the case. And even though purpuric rash can be seen in HSP also, you would have had other manifestations like GA involvement, arthritis. GA involvement in the sense patient would have developed abdominal pain, or patients would have developed melena, hematemesis, or probably intersusception. So GA involvement will be there in these children, and the patient would have had arthritis plus or minus an optional renal involvement. But here nothing is fitting into the HSP picture. And of course in the biopsy you would have seen IJ deposits around the vessels, even that is not given, so it's not HSP. Vaginous granulomatous, you know, it will usually present as pulmonary renal syndrome, which means patient would have had pulmonary involvement along with the renal involvement. That's very characteristic. And of course they tend to have ENT involvement, and definitely ANCA should have been positive. And what ANCA would have been positive? C ANCA would have been positive if it's a vaginous granulomatous. I don't think it's vaginous granulomatous anyways. You don't have any supporting features to say that. The right answer for this is cryo, because cryo can also present like small vessel vasculitis, and that's how they are producing this purpuric rash. And cryo is known for reducing the complements. Cryo is known to produce RF positivity. Okay, and cryo is going to occur on the background of hepatitis C virus, and this confirms that the patient is having a cryoglobulinemia. So the right answer for this question is going to be option D. And coming to MCQ number 25, this is the final MCQ of the day. So you have a 31-year-old woman with rheumatoid arthritis, diagnosed 5 years ago, asked for advice that she is considering starting a family. She currently has quiescent rheumatoid arthritis, which is well controlled on methotrexate. Which one of the following drugs is the safest use if she is planning to become pregnant? So of course the right answer for this question will be sulfasalazine. And if you look at the treatment of rheumatoid arthritis, the baseline therapy will be either methotrexate or leflunomide. Any one of these drugs is what I'm going to use, either methotrexate or leflunomide. On top of that, if the disease is not controlled, I can use sulfasalazine and I can use hydroxychloroquine. Often the combination of methotrexate, sulfasalazine and hydroxychloroquine is what we call as triple therapy. In most patients will be using triple therapy, honestly. Okay, in most patients there is going to be like all these three treatments, and if the disease is still uncontrolled, you can try biological drugs. If the disease is still uncontrolled, you can try biologicals and other innovative options. What are the biologicals? The first line biological is going to be anti-TNF alpha drugs. You basically have 5 anti-TNF alpha drugs. You have infliximab, etanercept, golimumab, certolizumab, adalimumab. Okay, and 5. Basically, you have 5 anti-TNF alpha agents. Any one of them you can try. And then you have anti-IL-6 receptor drug, that is tocilizumab. You have anti-CD20 drug, that is rituximab. And you have CTLA4 fusion protein, that is betalacept. Okay, betalacept is also approved. and you have anti-IL-1 like anakinra, which is very rarely used for rheumatoid arthritis, and we have alternative options like JAK inhibitors also. These are not biological drugs. JAK inhibitors are oral drugs only. Remember, biological drugs are given by parenteral route. Always, almost given by parenteral route. They are not given by oral route. But JAK inhibitors are basically given by oral route. So the best examples of such drugs will be tofacitinib and baricitinib. These are the alternate options to biologicals. First line biological is actually anti-TNF drugs. So actually you can combine biologicals with any of these drugs, not a problem at all. If you want to combine biologicals with sulfasalazine, HCQ and methotrexate, you can do that. If you want to combine them with leflunomide, you can do that. That's not at all going to be a problem. But the take home point is never ever combine two biologicals together. I'll repeat, never ever combine two biological agents together. That's a very, very important point. Don't ever combine two biological agents. And we have some older DMARDs. We don't use it nowadays. So like gold, T-penicillamine, and even azathioprine is considered to be a very important disease-modifying drug in patients with rheumatoid arthritis. But actually, azathioprine is a weak DMARD. It's not a very powerful and a very strong DMARD, by the way. So what are the drugs that are safe in pregnancy? I'll tick over here. So HCQ is safe in pregnancy, sulfasalazine is safe in pregnancy, and even azathioprine is safe in pregnancy. Remaining all the drugs are considered to be not very safe in pregnancy. Interestingly, anti-TNF alpha drugs are also considered to be reasonably safe in pregnancy, especially if you are giving after your first trimester. Anti-TNF alpha drugs are also considered to be reasonably safe in pregnancy. But in exam, they don't expect you to answer anti-TNF alpha. Rather, you can answer the basic drugs like sulfasalazine, hydroxychloroquine, and azathioprine. So these are the drugs that are considered to be safe when it comes to pregnancy. So in this question, the right answer is going to be option B, that is sulfasalazine. I think we have completed all the 25 MCQs, and this would have given an overall idea of what will be the expected questions in your AIMS exam, because it may not be the questions that can be directly asked in your AIMS exams, but rather I would say it's the topics that gonna repeat. So I've given the 25 topics, isn't it? So if you go through, like, I've covered almost all the important topics that have been regularly asked in the last 2 years AIMS or last 3 years AIMS. Look at the papers, you will understand yourself. There is no paper without ABG question. There is no paper without liver disease, especially portal hypertension. There is no paper without your rheumatoid arthritis management or SLE management. There is no paper without your questions on toxicology. Here I have mentioned about your acetaminophen poisoning with NSL system. So definitely you are going to get questions from these areas. There is no question without an ECG. So you're going to get one question from ACLS protocollar arrhythmia. So this is how the questions are going to cluster. So look at the papers carefully and prepare accordingly. So what are going to be the most important areas? So I just want to convey that, and with this I'm trying to finish off the session, and hope this session is of some use, and thank you very much. See you again in the next session, and till that, stay tuned and study well, and my best wishes for your INI-CET exam that's going to come soon. Thank you very much. Bye-bye.